So many of you might know me by Lauren Cook, like myself. I work here at the St. John Regional Hospital as a clinical research assistant. And a lot of what my focus is in my work is getting patients engaged and involved in research projects. So not only just through recruitment as participants, but also sitting on research teams, research committees. And that's kind of how I got interested in the topic of patient engagement. So I work for the Maritime Spore Support Unit, but I'm embedded in Horizons Research Services. The Maritime Spore Support Unit is one of 11 of CIHR's support for people and patient-oriented research and trials. It's quite an acronym, but primarily in the Maritimes, we have 4 sites, and we support, getting access to data, capacity development, and then things like patient engagement. So just so we're all on the same page, I'm just kind of going into the details of the term patient engagement and then just some kind of general ideas. So patient engagement. So if you can see on the screen, we have lots of interchangeable terms. So you have stakeholder engagement, public participation, citizen involvement, public involvement, patient and public involvement, and the list kind of really goes on and on and on. I know in the UK they lean more towards public involvement and citizen involvement. In Canada, and I would say probably more in the US, we use patient engagement. But this is just to kind of highlight that patient engagement isn't solely for patients. It's for anybody who's had a lived experience with a health condition, health experience. So you can have caregivers, family members, and then other stakeholders. I will be using the term patient engagement and patient partner, but when you're looking at patient engagement at other resources, you'll come across a lot of this language. So what is patient engagement? So I'm going to read out CIHR's definition just because it's a bit lengthy and I don't want to miss anything. But they define patient engagement in health research as occurring when patients meaningfully and actively collaborate in the governance, priority setting, and conduct of research, as well as the summarizing, distributing, sharing, and applying its resulting knowledge. So I'd like to kind of break this down a little bit further, and we'll kind of start on the first point that you'll see that patients aren't being engaged as participants as subjects. So doing a focus group or an interview where you're collecting data from a patient and using that to inform something, that's not really patient engagement. Patient partners are members of research teams. They sit on the teams. They help develop the research questions. They help to implement the projects. They are involved really in true patient engagement from the beginning until the end. So you'll kind of see there are various stages mentioned even in the definition through governance, priority setting, KT. But true patient engagement is having patient partners involved in your work from the beginning to the end. It's not always feasible, and sometimes a research team will notice halfway through a project that having a patient partner could really be beneficial. But true patient engagement through the eyes of CIHR is involved in all the stages of the lifetime of the project. And then finally, patient engagement or collaboration, as CIHR uses in their definition, is meaningful and active. So it's not only having patients involved at all stages, but it's having their feedback and ideas incorporated into a research project. So tokenism can be a real challenge with patient engagement. There are a lot of grants that require patient partners to be involved in the project. So a research team with no experience in patient engagement will recruit a patient partner, but maybe they're only involved in the KT strategy, or they sit in the meetings, but their feedback isn't really incorporated into the project. No changes can be made. So it's really got to be meaningful and active. And that's why I call it patient partner. You're in a partnership. They're on your team as another team member. All right. We'll get to the main part of my presentation of how can I start engaging patients in my research as partners. And I'd like to offer up 5 practical tips I thought that was manageable for a presentation. So the 5 things that we'll be going through is that teams really should be, 1, determining what knowledge you're seeking from a patient partner before you even begin. Number 2 is prepare practical items before engagement. Number 3 is a personal favorite, as you can see, budget, budget, budget. Number 4 is develop a creative convenience sampling recruitment method. And finally, number 5 is invest in relationship building. Start with the first one. Determine what knowledge you were seeking from a patient partner. So if you can see on the screen, this is a very simplified version of the life cycle of a research project. It's not always this linear. There are many, many steps. It will not fit on a slide. I've tried previously. This is really as good as it's going to get. But I just want to kind of be able to have this up so we can talk about when you're thinking about your project at all the stages that you might want to have a patient partner in, why would you want them involved at that stage? What could you possibly be getting from a patient partner at this stage? What changes can be made? So if you're going to have patient partners involved, they can and they should be able to contribute to each stage in the cycle. While I encourage research teams to have patient partners at every stage from the very beginning, it's not always feasible. And a research team really needs to determine what they want to seek and how they're going to be able to support patient engagement. So from the very beginning, the whole research team, without the patient partners involved, should have an initial and honest conversation about how they can support patient engagement and look at the timeline of their project and all these stages and think, okay, if we're going to have them in planning and preparation, what gaps do we think we have? Where do we think a patient partner can inform? If we're designing the study, what do we want to hear from patient partners? What should we be asking them? And also, this helps the team be able to have clear expectations when a patient partner is brought on, so they can say, we're actually having some real issues in selecting the tools. We need your opinion on, are these tools appropriate? So for example, if you're thinking, let's just start with the planning and preparation stage. Is it because you want to hear what their priorities are when you're developing the research question? Again, is it to ensure that the selected research tools that you're thinking about are appropriate for their population? Maybe you're making assumptions that, oh no, this will be fine for this group, I've used it before. But maybe you bring a patient partner on and they say, actually, that won't work for us. Or maybe it's because you're looking at your informed consent form and you think, this is getting pretty long. Like even I'm having a hard time reading this. Maybe we should have patient partners review it and tell us, what can be changed, what can be adjusted. So just having these clear items in your head before you even have a patient partner involved, thinking for the full lifetime of a project, it's really going to help shape expectations, but also it's going to help you identify gaps in your project, but be open to them identifying gaps that you maybe not have even thought of. Maybe they get to the data analysis section and they think, well, have you thought about this? If you're not open to that, patient engagement really isn't going to be as much value to you. So prepare practical items before recruitment. So I don't think any of us want to join a research project and really nothing is ready. We have no idea what's going on. So imagine how someone who isn't involved in research, is a patient partner, they come onto a research project and you don't really have anything prepared for them. So on the left, I have a list of documents that I recommend strongly as a need. These are things that you need to have ready before you start engaging your patients. On the right are additional items. I would say they're wants, but I think they're close in the development of patient engagement to becoming needs. So we'll just start with my needs list, the documents. The first one I really recommend that you have completed and ready to go is a terms of reference. So patients should be able to have a terms of reference list with who are the team members on your team, what is the purpose of the study, what's the general timeline, what are membership guidelines, and make sure it's in plain language. You might have one ready for your team, but when you look at it, it might not be patient partner friendly. So just having something that they can take home with them and say, okay, this is why we're doing this, this is why I'm going to be involved. Ground rules for meetings. It's good to have this just so they know how many meetings a year am I expected to attend? Is it 80%? Where are they taking place? And when you're putting this document together with your team, it also allows you to start thinking about, well, when are we going to have these meetings? Are they going to be at 2 o'clock on a Tuesday, or does this patient partner require it be in the evening or on a weekend time? Where are we going to be having these meetings? Is it going to be in our office, or maybe this population doesn't really want to attend meetings in a clinical setting, so maybe I need to start thinking about, having a meeting off-site. Confidentiality and authorship agreements are really important to have. I have heard some awkward conversations halfway through a project of, well, a patient partner thought they knew what confidentiality was, but they didn't really understand it. So just having laid out, this is what privacy is, this is what confidentiality is, this is what we expect that you'll keep private. If something was breached, this is kind of the process, because they're going to be involved. They want to know these things as well. And then guidelines for raising complaints. I really recommend having these available for patient partners because they might not feel comfortable making assumptions on how to raise a complaint. You know, is it an email to the PI? Do I send it to the whole team? So just making sure, you know, if you have a complaint or a concern, this is the person you send it to. You can bring it up at a meeting. If this is how you're going to bring it up at a meeting, you know, wait to the end, or, you know, this is the process established. And then for my wants list, so these additional items, these are becoming much more popular with teams, especially with the development of compensation guidelines. If you're going to be compensating or reimbursing any patient partners for their work, which we'll get to in the next section, having the direct deposit forms ready to go, an understanding of this is your mileage, this is what you'll be reimbursed for, just so there's no confusion once they get started. That can be really discouraging, thinking, oh, well, I'm going to be compensated for this, and then you get started and everything's out of pocket. And then a jargon and acronym list. So there's a really popular one available online called Jargon Buster, but it's very extensive. It's really for all healthcare, all health research terminology. But I recommend each team kind of pick and chooses a lot of the jargon that they commonly use in meetings that they're going to be using in their projects, and putting a list together for their patient partners that they can just reference to, because I think we've all kind of got lost in a meeting before where acronyms are flying around and you don't really know who's speaking about what. But a patient partner, you got to just assume they really know nothing, even though they quite possibly might know a lot. It's really respectful having that developed. This is my favorite one because it's a checklist and because it's becoming increasingly important, having a budget developed. It's one of the most overlooked things I think a lot of research teams don't consider as much when they're thinking about patient engagement. It's always recommended that a research project have this developed when they're putting in for a grant application, when they're looking to their funders, just so if you change your mind on patient engagement, you realize quarter of the way through, this is really what we need to improve our study, and you already have such a tight budget and there's no room to compensate or reimburse patients, you're going to have a really hard time moving forward. So my biggest recommendation is sitting down with your team and working through a budget solely for patient engagement. There are some really great tools online. There's a budget calculator that's an Excel template that you can just input. I have 12 meetings a year and this is the rate that we're putting it together. If you're looking for something like that, I'd be happy to share it with you, but it's a fantastic tool. And then I also recommend when you're thinking about just reimbursement for expenses, go beyond of just the parking. You have to think about out-of-pocket expenses for patient partners can be a real barrier to being involved, especially with certain populations. If you're looking at a more vulnerable population, having out-of-pocket expenses might be a complete deal breaker. So just thinking about your population, thinking about their needs, and thinking about what might limit them is really going to help you in the long run. And finally, compensation. Compensation is kind of a big conversation in patient engagement right now, especially in Canada. A lot of teams are developing their own guidelines. I know the MSSU, we've been working with our patient partners for some months now on developing recommendations. We should have them out by April. But compensation is a really strong way to demonstrate respect and acknowledge their time and expertise. On all the research teams we're sitting on, we're getting paid to be there. This is a part of our job, but these people are offering to share their personal health experiences to benefit your research. So to acknowledge, and they don't have to accept compensation, many people don't, but just having that offer goes a really long way. So we can go over the list real quickly. So compensation is a big one. Caregivers and care attendance is becoming a more budgetable item for research teams. If you're working with seniors, maybe you want seniors Caregivers of those living with dementia. Well, you want them to come to an in-person meeting. Well, who's going to take care of their loved ones? There would be a cost for them. Maybe they don't have, help that would be able to come in. So kind of thinking along the lines of, okay, if we're doing one workshop a year, how much will that cost for our 3 patient partners? Transportation, so do you have mileage? Are you going to need bus passes? Parking is really kind of, I think, the most standard one. Interpreters and translators, we're looking at doing more research with newly landed immigrants or the hearing impaired. You might have a patient partner where you're not looking at hearing impaired populations, but they are hearing impaired, so you might want to think about that ahead of time. Audio and visual equipment. Accessible meeting space rentals is a really big one. With a lot of populations, they don't want to come to a clinical setting to do research. It can be really off-putting. It can be really triggering, re-traumatizing. So if that's going to be an issue with your population, maybe we're doing 4 meetings a year and maybe instead we house it at Second Cup or we rent out a space at the YMCA. Just making sure you're thinking about that ahead of time. Accommodations, travel, conference fees, training opportunities. Maybe they're going to be involved in data collection. Maybe they'll be sitting in on your focus groups and there's a great focus group training, but it's $250. Well, just making sure you have that available. Food and beverages, and then printing. I recommend for a lot of patient partners having things in hard copies. You can send things through email, but a lot of people like to be able to just have a hard copy. And it's also, I went the extra step to print something out and make it available for you. All right. So develop a creative, convenient sampling recruitment method. I talk a lot about don't use jargon, but there was really no other way I could put this because a convenient sampling method is typically the most effective method when recruiting for patient partners. So the Alberta SPORE Support Unit put together these examples. So kudos to them, but I found it really helpful to summarize some great methods that are really used in patient engagement already, and then some that are becoming much more popular. So the first one is identify patients during their care who may be interested in being engaged in research. So maybe you're a nurse on a research team and you're asked, well, do you know any patient partners who might be interested? And you can think back about the patients that you see on a day-to-day basis and think, actually there was one patient partner who asked me if there were any opportunities for something like this. And if you don't know, you can look to your colleagues, you can look to your networks and say, like, do you have someone who you think might be interested? I know that our office, we work with an oncologist, and he was coming with a lung cancer research project, and he just thought, out of my lung cancer patients, who would be great to have involved? And so he has one from a rural population that he just saw in his care, and she expressed, if you have anything I could be involved in, I'd like to be involved, and he remembered that. A second one is ask your community partners or current patient partners who are already engaged about others who might be interested. So use your already established networks. So I know we had a meeting for the MSSU back in January where we were getting some feedback on how do we reach patient partners. Well, some of them said, well, if you're looking for this population, come to me. We have somebody at UNB who's doing homeless research on homeless populations. And he said, well, if you don't have that rapport already built or you don't have that network, you can come to me. So looking to people in your research community who might have relationships built that you don't have. Patient partners, if you have a patient partner who is already engaged in one project and can't commit to another, there's a good chance they might know somebody else who would be interested in being involved. The third is advertise where the patients are. This is a really, really big one, and this is probably the one I'm most excited about. So sometimes if you go down to clinical departments, you can see a recruitment poster for a project, but I don't know how many people are looking at these bulletin boards, but not a lot of people are going to their appointments looking for research opportunities on bulletin boards. It just doesn't happen. They might take a brochure or two, but it's just not something they're looking for. So you can do your clinical departments. You are going to potentially find some patient partners that way, outpatient clinics. Pharmacies are now becoming more and more willing to post things up. I know a COPD study, I found it at my local pharmacy. But go to where the patient partners are. It doesn't have to just be in their healthcare. So you can ask the YMCA. There are churches. people go get their hair done. You can ask hair salons, nail salons. You can be really creative, and you just don't have to think about their healthcare experience. Patient partners are people. They're going to go off and do normal things. There are other ways to find them. So go to where they are. Don't expect that they'll come to you or that they're looking for opportunities. They might have no idea unless you approach them. The fourth point is use social media. This is becoming more and more popular. You can get really creative with an infographic. You can make a 30-second little video with the research team saying, hey, we're the research team. We're looking for 2 people to join our research team. We'd love to have you, click on the link below. There are creative, quick ways that you can try and reach out. Some populations you're not going to get such a huge reception to. Some more senior populations, homeless populations, it's not really going to be a great tool. So you just need to keep your population in mind when you're thinking about this. And finally, connect with local and national support groups or voluntary organizations. And I can speak to experience that this was a really useful method for us. I know our office is involved in a research priority setting project, and we wanted to create a steering group of Canadians, 3 patients, we wanted 3 caregivers, and we wanted 3 healthcare providers for multiple myeloma. Well, we knew some in New Brunswick, but we weren't sure how we were going to access people out in BC, people out in Alberta. So we went to Myeloma Canada. They knew all the contact leads. They knew who their support group leads who would be interested in something like this, and they were able to facilitate that conversation, which made my job a lot easier. And they were able to quickly find people who would be interested. They would know a lot more than maybe you would. So be creative. Having a patient partner on your team from the very beginning will also kind of help you select one of these methods. They might tell you, no, don't worry about social media. No one from my support group checks social media. But a lot of us go to the YMCA to socialize and work out together. So maybe put it out at the YMCA. And just for those who don't know, Horizon has a registry of about 200 people from across the province of New Brunswick who have already indicated they're either interested in being involved in a research project, they want to sit on a committee, or they just want to hear about more research so they can share with others. So you can look to people like Horizon and say, hey, I have this research project, I need some help with recruitment, and I actually manage this registry. And we just put something out, and we usually get a great response of people who say, yeah, I'd love to participate in this, or I can't necessarily participate, but can I share this with my mother or my father? So just kind of look to your network, see what they have available, and it can really become useful for you. This is my last practical tip, so invest in relationship building. This is a bit of a buzzwordy section, but there really was no way to avoid it. My husband was laughing at me on the weekend because he was like, well, some of these people might have had conversations about some of these points after Valentine's Day with their significant others. So this might be fresh in the minds for some people. But the point being is that relationships take a lot of work, and having a patient partner on your team, that's a new relationship. So as much as it's buzzwordy, there are 4 core relationship building skills that I think are essential to patient engagement. And just to start off, before I go into any of the 4 components, I really recommend that each research team has one key point person on their team who would be responsible for maintaining these components, for maintaining the relationship. It can get a bit overwhelming when you have a team of 10, 20 people, and who do I go to about this? Who's checking in with me? So just make sure your research team, you've thought about who would be a really good person to be the check-in person, to be the person to answer the questions that a patient partner might have. So we can start with the first one, which is trust. So in patient engagement, trust is built on following up on the things that you're committing to do. So if you're saying to a patient partner, I am going to send you the pre-readings for our meeting a week ahead of time, make sure you do that. When you say, I'm going to have a debrief meeting with you after each meeting, make sure that you follow through. It's being able to commit to the patient partner so they feel comfortable, so they feel like they can share their perspective with you. You can demonstrate how their impact was, it made changes to your proposal. So maybe when you're After a meeting, you can say, hey, you made a really good point here. This is how we changed it. And that will help build trust of, I'm sharing my experience with you and you're actually doing something with it. It's valuable for me to be here. A second point is open communication. So communication and patient engagement should be done often. It should be done early. So again, there should only be really one person on your team who's that key person, who's doing the check-ins, who's doing the follow-ups, who they can openly and honestly share information with. So if they're not comfortable, they don't want to say it to a whole team, but with that one person, they can say, in that last meeting, I felt like I made some points and maybe I felt dismissed. So just having that relationship with one person can be really beneficial. This person should be using a communication method that best suits a patient partner. So some patient partners, they don't mind going through email. They don't mind a telephone call, but some patient partners really benefit from having an in-person meeting. They want to be at the meetings in person. They want to debrief in person. So make sure that you're using the method that best suits the patient partner. And that's something you can ask them from the very beginning. Hey, do you like updates through email, or is it best that I just call you and give you the updates? The communication should be culturally and linguistically sensitive. So again, in your initial team conversation, what language should we be avoiding? Again, being conscious of the use of jargon, making sure that you're just kind of reflecting on, okay, am I using language that maybe they wouldn't understand? Just checking in with yourself. And then the next point is remain flexible. So the project must be open to feedback from patient partners that can make minor or major changes to the project itself. So maybe patient partners are going to highlight that the research question doesn't address the priorities of the population. Maybe they say, that's actually not that important to us. Something similar that's important to us, could that potentially be the research question? They may inform you that the informed consent is too burdensome, it needs to be changed. Or that the recruitment strategy that you've developed, that's not necessarily going to work for us. So you just have to be able to be open to changes. Having a patient partner to join your team, and they're adding their feedback, they're sharing their perspective, they're telling you, what would really work for them, and then nothing gets changed. There's really no value in having patient partners engaged at that point. And then finally, respect. So respect can be demonstrated in a large variety of ways, and some of them I've already listed, but it can be as easy as, we're all just going to use first names when we're in our meetings. We're not going to be using doctor, none of that, just so it makes it more equitable for everybody, just so it's more comfortable for everybody. We're not going to be using acronyms. We're not going to be using jargon. We're going to ensure that there is designated time during meetings that patient partners are asked, what is your feedback? Do you have any final thoughts on this? And then again, demonstrating how their perspective, their suggestions were used. Make sure that you follow up with them and say, you had really good points. Either we weren't able to change it and here's why. Maybe it's a research process thing that they're maybe not aware of. Or, this was a great point, so we've actually kind of revamped all of this. Like, what do you think about that? But these are 4 things that are key to really all relationships. But for patient partners, I really think it's so important to keep these in mind. So just to wrap up, these are 5 items that I really think you should be considering before you start engaging patients in your research as partners. So determine what knowledge you are seeking from a patient partner. Prepare practical items before engagement, budget, develop a creative convenience sampling recruitment method, and invest in relationship building. So thank you very much. Do I just